We still have a few folks trickling in. I think it's probably time to get started. Thank you so much for joining Denton's today to talk about the One Big Beautiful Bill Act, and particularly its Medicaid provisions. I've got a couple housekeeping items to talk about to start, and then we can get into the agenda and introduce our speakers and go from there. So first and foremost, this is not legal advice. While all three of us are lawyers and either represent you currently or would like to represent you, what we say today is not should not be considered legal advice, and you should not act on it as if it is legal advice. The information today is current as of August 6th at 4:00 p.m. Like this piece of legislation, things are moving in Washington, D.C. fairly quickly. And so all of the information that we've provided is current as of today, but can change, as I said, very quickly over the next few days. There is a question box on the bottom of your screen. If you'd like to ask a question during the presentation, please just enter it into the question box. I, as moderator, will be taking a look at that, and will do my best to get the questions as they're coming in. And finally, just a broad overview point. This legislation has been enacted for over a month at this point. You'll see that this presentation will provide a general overview of some of the most impactful Medicaid provisions. But our goal here is to dive a bit deeper and identify some of the current unresolved issues and questions related to the legislation. And so we'll spend a little bit more time than you may anticipate on some of the slides, particularly at the beginning. We also have some slides at the end that provide some additional information regarding Medicaid eligibility and enrollment changes. We don't plan to spend a ton of time on those, but we included those just for your reference. So let's go to the next slide. So as I said, we will do some quick introductions. Then I'll provide a quick overview of the One Big Beautiful Bill Act. Then Charlie and Claire will take on the Medicaid provisions and talk about everything from provider tax changes included in the law to state-directed payment limits to mandatory work requirements and the Rural Health Transformation Program. As I said, those other Medicaid provisions, we're going to sort of leave at the end so that we have a little bit of time for questions as well. Next slide, please. All right, next slide. All right, so with us today, we have Charlie Luband and Claire Bornstein. You can read more about their practices here. They are both national Medicaid experts. They've devoted their entire career to the Medicaid program, in addition to Medicare and some of the other programs within healthcare public policy, and have navigated pretty significant changes to that program as it's evolved over the last however long. And my name is Callan Smith. I haven't done that yet. I'm a managing associate at Denton's. I am a healthcare lawyer and a healthcare lobbyist. I've been in Washington, D.C. for about 15 years and actively lobbied on this bill. Next slide, please. All right, so we can talk quickly about the One Big Beautiful Bill Act. Next slide. So as you all know, this bill was passed via budget reconciliation. In total, it amounts to nearly $5 trillion in new spending. The vast majority of that new spending is dedicated to extending or expanding individual and corporate tax cuts. There's also additional funding in the bill for defense spending, things like shipbuilding, and additional border security and immigration and customs enforcement. The reason that we're here today is because in order to offset some of that spending, the bill includes about $1 trillion of cuts to Medicaid. We have a little note at the bottom here that says that any of these numbers that we're using, they're specific. They come directly from the Congressional Budget Office's July 21st, 2025 scoring of the One Big Beautiful Bill Act. So in addition to the $1 trillion in Medicaid cuts, which we're going to focus on throughout this webinar, There is about 300 plus billion in cuts to federal student loans and federal student loan repayment programs that could ultimately impact the healthcare workforce. And there's also another 100 billion plus in cuts to nutrition assistance. Finally, the bill also increases the national debt ceiling by $5 trillion, which extends the country's borrowing authority to likely sometime into 2028. Next slide, please. All right, so we're going to get started on the Medicaid provisions. Again, if you have questions, please log them into our question box. And I will flip it over to Charlie to start and talk a little bit about provider taxes. Thanks, Charlie.
No problem, Callum. So the first, some of these areas that we're focusing on are some of the largest sort of cost savings in the bill, as well as sort of Claire will also talk about one of the expenditure pieces, but most of these are cost savings. And so the first section that we were going to focus on is this provider tax, these changes to the provider tax rule that's included in two sections. The first section is section 71-115, the provider tax freeze. And this really inhibits the expansion of provider taxes. There are some publications that have said that this actually prohibits any new provider taxes, and that's not exactly right. But it definitely inhibits the expansion of provider taxes, and in expansion states in particular, requires that they shrink. Specifically, what does it do? Specifically, there is something called the indirect guarantee hold harmless percentage. This is a issue that is sort of deeply embedded in the Medicaid statute. And it basically says, look, if you're below this percentage, this is how much your taxes are as a percentage of net patient revenue specific to each healthcare item or service that you're taxing. If you're below this percentage, then you don't have to worry about certain issues. In fact, you don't have to worry about whether or not there's an indirect guarantee that most providers will receive their tax funds back. That indirect guarantee hold harmless percentage is fixed in statute right now, or well, actually, up until the OBBBA, was fixed at 6%. Under the One Big Beautiful Bill Act, this hold harmless percentage will be frozen at the percentage of net patient revenue for each state, for each class or service of taxes imposed and enacted as of July 4th, 2025. So this applies on a state-specific basis, and it applies to healthcare items and services. What are healthcare items and services? This is actually something that is known. This is in the statute, the existing statutes and the existing regs. Healthcare items and services are all sorts of things such as like inpatient hospital services, outpatient hospital services, nursing facility services, professional services. There's a list. There are interesting things that are not in that list, and they're not affected by the One Big Beautiful Bill Act. If a state does not have an existing tax on that healthcare item or service, then it is true that no new tax is possible. And that's because the percentage as of July 4th, 2025 would be zero. And if you're frozen at zero, creating a new tax would obviously put you above zero, and that's a problem. However, this percentage, whether it's 6%, as it continues to be right now, continues to be calculated in the aggregate at the state level. And technically, the changes do not take effect until October 1, 2026, or really federal fiscal years beginning on October 1, 2026. So federal fiscal year 27, which indicates that states and localities may still increase provider tax rates over the next year to secure additional provider tax revenues. It's less clear if you are at zero, whether you can increase, because even though the whole section really only takes effect until October 1, 2026. They're also sprinkled in as of the date of enactment in a number of places in the bill. So certain things that aren't quite clear is what happens between now and October 1, 2026 in terms of how that freeze will work. Although it does appear that you can increase, or states can increase tax rates, particularly if they already had a tax on a particular class or item of service. Next slide, please. So in expansion states, we're still in section 71.115. In expansion states, there's an additional wrinkle. So the base is, all right, you're stuck at where this applicable percentage, this percentage that's calculated as of the date of enactment, July 4th, 2025. If you're in an expansion state, then starting in federal fiscal year 28, so October 1, 2027, it's going to be the lower of where you were stuck at July 4th, 2025, or these percentages that are put out on the slide. So there are specific percentages starting in 28, going through 2032, and then future years after 32, it stays at 3.5%. So if you're in an expansion state, you are going to be required to be less dependent on provider taxes, because that percentage of taxes collected over net patient revenue is going to go down year by year. And there are many states that have various taxes that are up at 6%. Those are going to have to go down sooner than states that are up at 4%, where you might not actually feel anything until 2031. If you're at 6%, you will feel it in 2028. Now, there are some exceptions. Assessments on nursing facility services and intermediate care facility services are exempt from the phase down, but they do have to remain at the rate enacted and imposed as of July 4th, 2025, that frozen rate that I talked about on the prior slide. Non-expansion states also have to remain at the enacted and imposed frozen rate as of July 4th, 2025. An interesting wrinkle is it doesn't look to me like you can escape this reduction by moving from an expansion state to a non-expansion state. A state is defined as an expansion state if in any year after 2014 they covered the expansion population. And so a state can't sort of turn into a non-expansion state for purposes of this provider tax provision, because the definition is worded in such a way that they will always be an expansion state. Now, whether or not CMS may or may not try and get around that through regulation is definitely one entirely open question. Let's go to the next slide, and I'm going to talk about state-directed payment. Or actually, no, one more. Forgot. There is another provision about provider taxes that's different from talking about this indirect guarantee hold harmless percentage. There is a provision that implements new standards regarding states that request waivers of uniformity in the context of a provider tax. Now, I work on these issues all the time, and I realize that I've just given you a word jumble that may not make sense to a lot of you. A provider tax generally has to fit three requirements. It's got to be broad-based, which means if you're taxing all nursing homes, you have to tax all nursing homes. That's what broad-based generally means, although there are some exceptions. It has to be uniform, which means that if you're going to tax nursing homes, you have to tax them at the same rate. Now, there are some exceptions even in that definition. And then the third one is that you can't have a hold harmless, and that indirect guarantee hold harmless that we talked about in the prior two slides, in some sense is dealt with by that indirect guarantee hold harmless issue. Now, this is focusing on uniformity. A state can ask for a waiver of uniformity, and at least in the current regulations, there's basically a statistical standard, and if you meet the statistical standard, then it says CMS will approve that waiver request. This legislation says that a tax would not be considered to be generally redistributive. In other words, they won't approve it if this new standard, which basically has to do with Medicaid units, is not satisfied, whether or not sort of the Medicaid units bear more of the tax than the non-Medicaid units. It's a very fuzzy test as opposed to the test that is in current regulation, which is a pure statistical test. Either you meet the statistic or you don't. This is a much fuzzier test. What's interesting about this language in the legislation is that, well, there are a number of interesting things. One is, while this legislation was pending, CMS issued a proposed rule and took comments on the proposed rule to do something very similar. It's a very similar test set out in regulation to what was set out in legislation, except for the fact that the regulation would apply to both broad-based and uniform waiver requests, not just uniform waiver requests. The proposed rule, of course, was only a proposed rule, and CMS would presumably take comment, or, well, they did take comments, would presumably consider those comments, respond to those comments, and issue a final rule. And so it's unclear now that the standard has, at least for uniformity, has been sort of put into the law. It's unclear what the law, whether the proposed rule actually has any need except on the broad-based side. In addition, there's some weird language in the effective date for this this legislation. The effective date for this legislation says that it is effective upon enactment unless the secretary decides that there should be a transition period. Which and to my knowledge, the secretary has not yet said whether or not there should be a transition period. So I think it's actually unclear whether the legislative language is or is not currently effective. So there's a bunch of uncertainty about sort of the effectiveness of this legislation, the provider tax proposed rule that sort of dovetails with this legislation, and whether or not regulations are happening or not happening. All somewhat interesting. Next slide, please. Another major change had to do with state-directed payments. Now, state-directed payments are an interesting category of supplemental payments that exist in the Medicaid program that occur in the context of managed care. CMS has a general rule that a state may not direct how managed care organizations pay their providers. But in 2016, they implemented an exception to that general rule and said, if you follow these regs, then you can direct. And states have actually really jumped, with both feet into doing these state-directed payments. There have been a number of sets of regulations, including a regulation just last year, which allowed states, among other things, to sort of go up to the average commercial rate when setting these state-directed payments. This provision responds to that regulation from last year and says, all right, hold on a sec. For new state-directed payments, sort of anything post-enactment, you are going to be limited to 110% of the total published Medicare payment rate for non-expansion states and 100% of the total published Medicare rate for expansion states. So it's clear that they're coming away from sort of, yes, you have states, you have permission to go up to the average commercial rate, to something that is the total published Medicare payment rate. Now, the legislation actually, up until the last moment, said in its terms, total published Medicare payment rate. In the last iteration, it actually instead did a cross-reference to the regulations, where the regulations define total published Medicare rate. That is amounts calculated as payments for specific services that have been developed under Medicare Part A and Part B. This language, when it was inserted into the regulations in 2024, so last year, was inserted solely for the purpose of saying a state does not need to go through the written approval process if they use the total published Medicare payment rate. And CMS made clear that it's a very narrow definition. We're not meaning a reasonable estimate of what Medicare would pay, something called the upper payment limit, which is defined elsewhere in Medicaid regulations. And they basically said, look, we don't have to define this all that well because it's for a narrow exception to the state-directed payment written approval requirement. In this context, it is extremely unclear what total published Medicare payment rate is intended to mean. There are some Medicaid payments for which there is no total published Medicare payment rate. And that would be okay if you're saying, well, as an exception to the written approval requirement, you can do it if there's a total published Medicare payment rate. But if you're now limiting states to, you can't do anything above either 110 or 100% of the total published Medicare rate, states are without guidance as to what that means. CMS may use this as an opportunity to revise the regulations, provide a more detailed, more applicable definition, but we don't know yet. Something that's interesting, these limitations only apply to the state-directed payments that go through managed care. They do not apply at all to Medicaid fee-for-service supplemental payments, including those Medicaid fee-for-service supplemental payments that have been allowed to go up to the average commercial rate, such as physician payments. And so that's something interesting. Next slide, please. Oh, actually, let's go back a slide, because let me talk about some other, I thought we might have mentioned some of the other ambiguities. Could be there was a slide that got lost somehow. For certain state-directed payment programs, those that are grandfathered, yeah, there really should be another. We somehow lost a slide in the slide deck. If you had a state-directed payment for which a completed preprint was submitted before the enactment date of the legislation, before July 4th, 2025, that is a grandfathered preprint under the statute, under what passed in the One Big Beautiful Bill Act. Now, there are two other categories that are also grandfathered state-directed payments. Those categories are somewhat subsumed into this definition of if you had a completed preprint that was submitted before July 4th, 2025, for a rating period within 180 days of July 4th, 2025. The other two categories, one category had to do with rural providers, and another category had to do with things that were in process before May 1st. But those two, I think, really are subsumed into the latter category. So one question that's outstanding is whether or not CMS will attribute anything to those other two categories, or whether really all that matters is whether or not you have a state-directed payment for which a completed preprint was submitted before July 4th, 2025. Tease up the next question. What is a completed preprint? That is not defined by the legislation, and although God knows a lot of members of Congress that were pushing for this additional language, which was added at the last minute, have strong feelings about what a completed preprint means, but it's unclear exactly how CMS is going to interpret that and whether or not there'll be blowback based on on how that interpretation comes through. But if you have a grandfathered SDP, then as of the first rating period after January 1, 2028, those preprints have to decrease by 10% to these limits that are up here on screen, to 110% of the total published Medicare rate or 100% of the total published Medicare rate. But there is an awful lot of ambiguity because we don't know whether those we don't know what the top is, what the decrease is from. If you have a grandfathered SDP, does that mean the amount as of July 4th, 2025? Is that top of the range that you're at or that you're decreasing from for the first rating period after January 1, 2028? That's unclear. The legislation doesn't say. When it says,
Charlie, really quickly on this specific point, we did get a question, and the question is, this might provide you sort of an example to further explain this. Does the reduction in the percentage of Medicare for directed payment? Yeah, you saw it. Okay, great.
I see it, and actually, I was going to. I will actually click the answer live button because I was just getting there, just getting to that next thing. It says reduce by 10%. But it does not tell us what that means to reduce by 10%. I think the person who asked the question said, does that mean if you're at 150% of Medicare that you go down by 10% so that you're down to 140% of Medicare? Maybe. Maybe not. Maybe it means you go down by 10% of that total payment level that you're at. Or maybe you go down by 10% of the difference between that total payment level and that endpoint of 110% or 100% of total published Medicare rate. But remember, we don't even know what that bottom end point is either. So there are an awful lot of ambiguities about what's at the top, what's at the end point, and how you get from here to there, including what that 10% reduction means. Finally, as just another ambiguity, oh shoot, I've lost my train of thought. I hate it when that happens. But there is yet another. There are still more ambiguities in sort of how this SDP reduction is going to occur. Actually, I know what it is. We don't know what you can do between July 4th, 2025 and that first rating period after January 1, 2028. There's actually nothing in the statute that says you can't increase from July 4th, 2025 if you have a grandfathered preprint. You also don't know what it means, how you can lose that grandfathered status. And are you still a grandfathered preprint if you add a new provider? If you lose a provider, if a provider closes, is this still the same preprint? These are all questions we don't know. And presumably CMS is going to have to issue guidance or regulations in order to sort of help inform those questions. I see another question in the chat about what is the conventional rate as a percentage of Medicare. That is, I assume what you mean is actually what is the average commercial rate as a percentage of Medicare. I'm not sure what conventional means. And it's a very difficult question to answer because it really depends on the particular set of providers you're talking about, the services you're talking about, whether you're talking about hospital services or physician services. It also depends on what state you're talking about and what region you're talking about. These are very fluid, variable issues. With that, actually, I think I see the time and I want to make sure Claire has adequate time. So why don't we go to the next slide and I will turn it over to Claire. I will keep answering questions in the chat or in the Q&A.
Thanks, Charlie. So still very much in the Medicaid provisions, but transitioning to a slightly different issue, which is the mandatory work requirements, section 71119. And I think when talking about either community engagement requirements, commonly known as work requirements, it's worth taking, just kind of a very brief step back to acknowledge that promoting or requiring work as a condition of Medicaid coverage is not necessarily a new issue or a new policy preference, particularly amongst Republicans. Dating back to, I think, kind of 2017, 2018, Arkansas and Indiana, for example, had voluntary programs. During the first Trump administration, the Trump administration CMS issued guidance encouraging states to implement work requirements through Section 1115 demonstration waivers, and a number of states did so. But obviously, with the change of administration, with the Biden administration, with the COVID-19 pandemic, for a variety of different reasons, most of those programs were withdrawn or overturned. And to date, we actually only have one state that is currently administering a community engagement work requirements program, that state being Georgia. Now, with the enactment of the OBBBA, work requirements are mandatory, requiring all states to verify at application and at renewal that applicable individuals, as defined in the statute, largely as individuals in the Medicaid expansion group, meet 80 hours of work activities per month, which is largely about 20 hours of work per week. And notably, the mandatory work requirements, that $326 billion in savings, is the largest cost savings of any of the Medicaid provisions. And, many of those savings could end up being a result of just individuals failing to comply with these new work requirement provisions, and therefore either becoming uninsured by losing Medicaid coverage or failing to qualify for eligibility at all. And so when we're talking about the mandatory requirements and the qualifying engagement for the qualifying individuals, such activities include work, community service, work programs, education activities, or some sort of combination thereof. And while the statute identifies certain qualifying engagement activities, it may be that, in issuing guidance in the coming months and years, and as states develop their programs and implement their programs, what, kind of constitutes a qualifying engagement may vary. But I think it's also important to keep in mind that states are required to exempt certain categories of Medicaid enrollees. This is consistent with kind of prior guidance and prior state applications through demonstration waivers, that certain individuals are commonly exempt from these programs. For example, and this is just a sample of the exempt individuals that are in statute: adults with a dependent child that is either younger than 14 or disabled, blind or disabled individuals, individuals with a substance use disorder, individuals, with serious or complex medical conditions. So again, even if you were enrolled in Medicaid via the Medicaid expansion, you would be exempt from the requirement if you met one of these qualifying conditions. Next slide. And so what is unique to the OBBA, or I should say unique compared to most other state programs to date, but consistent with Georgia, is that states are required to verify that individuals applying for coverage meet the requirements for the qualifying activities. And that makes these work requirements a condition of eligibility, where most states that have previously submitted work requirement programs have designed the programs where the qualifying work have been a condition of maintaining enrollment. Here, it really is a condition on eligibility upfront. So not only do you have to meet the requirements when applying for coverage, they also have to, be able to continue to show that proof of work for consecutive months to maintain their coverage. And so then, you know, if a person is denied or disenrolled due to a failure to meet these requirements, they also become ineligible for the advanced premium tax credits under exchange coverage. So these work requirements are effective no later than December 31st, 2026. Under the statute, HHS, you know, is required to issue an interim rule, I believe, next year to provide states with certain guidance in how they need to design and stand up these programs. But like many of not only the Medicaid provisions in the OBBA, but a number of different provisions throughout the law, there are very, very tight timeframes when it comes to kind of design, implementation, et cetera. And so with an interim rule coming at some point next year and states required to implement these programs for expansion adults beginning effectively, you know, January 1, 2027, it doesn't leave states with much time to really kind of design these programs, enter into whatever kind of arrangements they need to implement these programs, et cetera. So it really could, you know, impose a significant administrative burden on both states and also whatever entities states intend to kind of work with and rely on for purposes of their programs. So kind of one question, you know, an issue that we've been thinking through is if you are, you know, an expansion state that largely administers your Medicaid programs through in partnerships with managed care plans. If those managed care plans, you know, handle a lot of kind of your eligibility enrollment screens, member enrollment, et cetera, you know, what could states potentially flow down to their health plan partners for purposes of the work plan requirements? What would those arrangements look like? And there would just be a lot of different steps along the way just to stand up these programs, let alone kind of screen and, you know, have kind of any protections in place to ideally avoid the kind of, you know, disenrollment that people fear coming from these new requirements. Again, you know, the OBBA does provide for a limited grace period for states. So while the effective date is January 1, 2027, states are exempt from compliance if they can show they're making good faith efforts to stand up these programs, but they would still have to come into compliance no later than December 31st of 2028. Should we go to the next slide, please? Brian, would you mind advancing to the next slide? Thank you. So we're now going to talk about the Rural Health Transformation Program. And it's just worth saying we've included the Rural Health Transformation Program in our presentation, one, because it's kind of become a real hot topic in when talking about the OBBA healthcare provisions and provider provisions. But it is important to note that the Rural Health Transformation Program actually is not a Medicaid program. It is in the same subtitle in the OBBA as all of the Medicaid provisions, but it is a grant program. It's the type of program that you would typically see administered through HRSA. Interestingly, they enacted the program under Title 21 of the Social Security Act, which is also the Children's Health Insurance Program. Whether or not some of that is just kind of drafting error as a result of just a very rushed process is unclear. But wanted to be sure to touch on it, but clarify that it is actually not a Medicaid specific program, despite where it is in the bill itself. So Brian, if you wouldn't mind moving to the next slide. So the Rural Health Transformation Program, hearing a lot about it. It is a 5-year grant program where kind of everything we've been talking about in the Medicaid context are all cuts and savings. As Charlie noted at the beginning, the Rural Health Transformation Program is really an expenditure. It is $50 billion for a rural program that in many ways has been kind of marketed and discussed as a rural provider relief fund in some ways. But when you really start to dig into the program itself, it is much broader than just a rural hospital or rural provider program. It provides $10 billion per fiscal year for 5 years to CMS to administer to states that successfully apply for the program. So states are obligated. And again, it is limited to the 50 states, does not apply to any of the territories, and I don't think it even applies to DC. So states are obligated to submit applications to the administrator to apply for the funds. The applications, which must include a detailed rural health transformation plan. What that plan has to include, what that looks like, is loosely described in the statute itself. But those applications have to be in no later than December 31st of this year. And interestingly, applications have to be submitted by the end of the year, and the administrator also has to review and then approve or deny all applications by the end of this year. So it is a very, very short time frame for states to apply and for the administrator to review, approve, or deny the programs. So if accepted to receive payments, a state will receive payments for all 5 years of all 5 program years. It's not like they have to annually apply or renew. Your guaranteed payments over the 5-year period. And then Brian, if you could advance to the next slide, please. And so CMS determines the annual allotment for each state with an approved application pursuant to this allotment that's set forth in the statute. Again, it isn't incredibly detailed, but provides some guidance. 50% of the annual allotment is divided equally among all of the states with an approved application. And the other 50% is divided among such states in an amount determined by the administrator. It's in part based on states' rural population, the number of rural healthcare facilities, and the situation of hospitals in the state, but does seem to leave the CMS administrator with a significant amount of discretion in how he will allocate those funds. And what's really interesting about this program, one, again, as we discussed, the timing is really quite limited in the sense of when a state has to apply and when the applications will be approved. So even on, in calls earlier today, are aware of 2 states that are consulting with providers on the type of information that they, need and should include in their state application for program funds. But when states are submitting the applications, one of the things that they are supposed to describe is how they will use the funds. And the statute does outline kind of a certain number of authorized uses of funds. A state has to identify at least 3. Only one of those authorized uses, and I believe they're anywhere from like 12 to 15, specifically applies to rural providers. And so I think there's limited guarantee that, program payments will end up with providers. One, because the funds do not flow directly from the administrator to providers themselves. They go from the federal government to the states, and then the states will allocate those funds pursuant to their transformation plan. And depending on how they structure it, it may or may not result in payments flowing down to rural facilities. And so I think at this point in time, there are a lot of conversations at the state level about, should we apply? We state, when should we apply? How quickly can we get our application in? And, how should we structure our transformation plan? Because I think a lot of us on the line know that one of the reasons there was such attention paid to rural communities and rural healthcare providers is that rural healthcare providers really are in crisis. Every day we hear about rural facilities closing. And so while this program was really kind of marketed as a rural provider relief fund, how exactly that plays out over the next 5 years somewhat remains to be seen.
Claire, we actually have a great question in specific to the Rural Health Transformation Plan and whether or not there are what types of providers are eligible for the fund. So is it totally up to the state? Are there limits to the types of providers? For example, if a hospital is reclassed as rural, are they then eligible where they might not be eligible otherwise? Can you get into that a little bit?
Absolutely. And Cal, that's a really great question. So the statute defines both rural healthcare provider and rural facilities. And the definition of rural facilities is incredibly broad. It's incredibly broad. It really kind of identifies any type of provider that could be providing services in a rural area. And to the question whether or not that, could include a rural referral center, as the statute is currently drafted, it seems like it could. And so, large public facilities in urban areas that are classified as rural referral centers, it seems under the statute could be eligible for payments depending on how the state structures their application.
Great, thank you. We want to do next slide. Okay, I can jump in here. So these were some of the other Medicaid provisions that we were going to go through very, very quickly. We're actually not even going to talk about them because we have about 10 minutes left to answer any questions. But as you all know, that this is a massive bill. It includes a significant number of Medicaid provisions. It also includes provisions related to Medicare. It also includes provisions related to the Affordable Care Act, and significant changes to eligibility and enrollment requirements across those broad categories. And so we've got some information here on some of those provisions, other provisions that, this was not intended to be a comprehensive guide. So other provisions that might be interesting to some of the folks that are on the call right now are one that would limit Medicaid payments for emergency Medicaid to what the state's normal FMAP is. Currently, individuals who would otherwise be eligible for the Medicaid expansion population were able to draw down 90% the Medicaid expansion FMAP for services provided to those individuals. The law changes that and reverts it back to what the state's sort of quote unquote normal FMAP is. That's just one example of something that we didn't include, but is pretty important and will impact Medicaid reimbursement and financing for states over the next several years. Brian, I think we can hop through these, and then it looks like we have another question on state-directed payments, Charlie.
Sure. Yeah, so the question is whether or not preprints using ACR have been recently approved, how many are pending, and will CMS limit them to Medicare? They're up until July 4th. CMS was clearly still approving state-directed payments. There are on the CMS website, there are preprints that were approved on June 23rd, June 25th. I think they're actually, and I heard from somebody that that they know of a state-directed payment that was approved on July 1. And CMS certainly has been approving up to or close to the average commercial rate for many of those states. I have no idea how many are pending. I did hear during the process of the One Big Beautiful Bill that there were at one point 180 preprints pending in front of CMS. I have no idea whether there still are. I don't know whether or not, I don't know what CMS will do about limiting them to Medicare or continuing to prove, and if they fall into that grandfathered preprint category, if they were completed preprints submitted prior to July 4th, 2025, I don't know whether or not CMS will or will not approve up to the average commercial rate. And certainly a lot of states submitted preprints in advance of that date in hopes that CMS would. But the interesting thing about state-directed payments is CMS approval has always been somewhat discretionary, and so it's unclear. And that I didn't list that explicitly when I was listing all of the things that are unclear about the grandfathered state-directed payments, but that is certainly another aspect that is unclear. There are a couple of other questions in the.
Yeah, let's flip back to Claire, actually. So Claire, while we were talking about the Medicaid work requirements, Donna asked how disability how is disability determined regarding the work requirements generally? My understanding is that there are some specific references to various statutes within the different eligibility groups, but maybe you could talk a little bit more about that.
Alan, I believe that's right, and would be more than happy to follow up with with additional information without seeing the statute in front of me. I don't know them off the top of my head, but Callan, I think you're exactly right that there are specific references either to other references in the statute, waivers, etc., that help define those categories of exempt populations.
Great. And so then there's another question in the chat about potentially more audits. And I have a sense that this is specifically referencing the provision in the OBBBA that had to deal with perm rates. Charlie or Claire, do you want to talk a little bit about how that payment error rate mechanism might be impacted by reducing the percentages from, I think it was like 6 or 7% down to 3.5%?
Yeah, I mean, to be completely honest, I haven't focused in much detail on that provision, but I do think there are a number of, and there's always the possibility for additional audits. And I think certainly a change in the perm rate is one category where there could be additional audits, but there could be plenty of other areas of additional auditing, spurred directly by the One Big Beautiful Bill. It is making substantial changes to the Medicaid program.
And then we have another question about competitive bidding. I don't know that I saw any specific changes to like DME competitive bidding within the OBBBA. But then there's the second part of the question is if there's grants for Medicaid enrollees that do not qualify for Medicaid, if there's other grants, like maybe they're referencing emergency Medicaid. Maybe you can talk a little bit more about that, Charlie.
Sure. Well, it's interesting. I mean, years ago at this point, there was a brief, a very brief program for immigrants who did qualify for Medicaid. It was called Section 1011, and I can't remember even what massive bill it was in. There is nothing like that in this. They're really a lot of these provisions are expected to reduce enrollment, whether it's because of the mandatory folks that don't meet the work requirements or don't meet the paperwork requirements attendant to the work requirements. There's also in the eligibility and enrollment slides, we've got information about additional redeterminations that are needed. More states are going to have to redetermine eligibility for individuals. Some of those folks are just going to, as a result of paperwork, sort of drop off eligibility rolls. There really are not other grants made available for these Medicaid enrollees that no longer qualify for Medicaid. There is no increase in sort of DISH funding, which Medicaid DISH often can cover the cost of providing care to uninsured individuals, at least in hospitals. And in fact, one thing that wasn't included in the One Big Beautiful Bill Act was was forestalling reductions to DISH payments that are supposed to go into effect on October 1. And so there are a lot of healthcare providers and state Medicaid agencies and folks out there who are very concerned that there will be an increased number of uninsured individuals and that they will not have other resources, and that burden will probably mostly fall on providers that see those individuals. I think, and Callan, I can't recall off the top of my head, I think CBO does score these kind of things. CBO does sort of estimate what the change in insurance status is as a result of legislation like this. And I think it was something like 10 million, or how many more was it?
Yeah, that's right. So it was 10 million if you do not account for, so CBO initially estimated at 11.8 million, and then they estimated the revised version down to 10 million. More people that they're estimating will be uninsured by 2034. And that includes, I think it's like 7 or 8 million within Medicaid, but then there's a couple other million that will lose coverage through like the Affordable Care Act that won't be able to obtain coverage through Medicaid or other sort of programs.
And I think you were about to say, and this doesn't even account for the expiring advanced premium tax credits or enhanced advanced premium tax credits that have been around since COVID, but are due to expire at the end of this year, right?
That's right. And so CBO actually estimates that allowing those tax credits to expire will result in an additional 5 million individuals that will no longer have health insurance by the same date over the same budget window. So depending on what kind of Congress does, and this is actually a great kind of transition to closing this webinar, to talk a little bit about what's next. So Charlie raised Medicaid DISH. So as Charlie mentioned, the Medicaid DISH cut is scheduled to go into effect at the end of this fiscal year, so on October 1, 2025. There's a number of other healthcare programs, including things like Medicare telehealth flexibilities, including things like funding for community health centers that also expire at the end of this fiscal year. We, from a healthcare policy perspective, we're anticipating that Congress will put together a government funding bill that will also include an extension of a fair amount of those programs. We generally refer to them as healthcare extenders. And then there's potential for sort of a larger agreement later this fall, but that's far from certain. You know, I mean, one of the things that has marked this Congress is an incredible amount of uncertainty, and once an agreement is made, they act incredibly quickly. And so I think that the OBBBA Act is a perfect example of sort of federal healthcare policy making right now. And I think we anticipate seeing more of that in the near future. But let me close. Charlie and Claire, thank you so much for this overview. If you have any questions about anything that you've heard here today, we will be sending out the presentation in this recording so that you have all of our contact information. Please feel free to reach out to us. You know, this is what we sort of live and breathe and do, and we appreciate your attention. So thank you.